Welcome to Derm Drop. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other sources in the dermatology community. Episode 21 includes 4 segments, starting with HS procedures, which ones have the best aesthetic, complication, range of motion, and recurrence outcomes, followed by atopic dermatitis systemics and surgery. How does eczema affect surgical outcomes, and should you discontinue biologics or small molecules perioperatively? Then Pott, Puffy tumors, must-know red flags, and what to do and not to do when you spot one. And finally, alopecia medications for breast cancer patients. Which ones are safe and which ones are not? It's fun stuff as always, so let's get started. Your HS patient's tunnels and scarring are too much for a simple de-roofing procedure. Now what? A systematic review published November 12, 2025, in the Journal of Cutaneous Medicine and Surgery evaluated the outcomes of various hidradenitis suppurativa surgical modalities. Here's what they found. Wide excision without closure, that is, healing by secondary intention, produced moderate rates of complication, 7.3%, recurrence, 17.2%, and restricted range of motion at 1.2%. But it had the highest cosmetic dissatisfaction rate at 4.7%. So highest, but not that high. Primary closure had the highest rates of complications, over 29%, and recurrence at 38%, with relatively high rates of cosmetic dissatisfaction at 3.8%, and restricted range of motion at 2.7%. Skin flaps also showed high complication rates at 25%, perhaps due to reserving them for severe cases in challenging regions. But recurrence rates were lower at 11.2%, with only 0.3% cosmetic dissatisfaction and 0.5% restricted range of motion. Grafts resulted in a lower complication rate at 13.2%, and even lower recurrence rate at 9%, with relatively common restricted range of motion at 2.5%, and moderate cosmetic dissatisfaction at 2.9%. But don't forget about the donor site morbidity involved in grafts. Sequential excision, typically staged removal with reconstruction, resulted in minimal complications and no cosmetic dissatisfaction, but had high recurrence rates over 28%. Laser surgery, primarily CO2, demonstrated the lowest rates of complication at 2.2% and recurrence at 5.7%, with only 0.2 cosmetic dissatisfaction and no range of motion restrictions, but has limited efficacy in deeper disease, so it performs best in early advanced HS. It's useful data for informing your surgical or referral strategy and providing patient guidance. But what's better than the best surgery? No surgery. And the best way to avoid surgery is to strike fast and hard medically. A 2020 study found that patients with earlier diagnoses had fewer surgically treated sites. Conversely, about 90% of the patients with the longest diagnosis delays underwent surgery. A 2023 study showed that fewer patients required surgical interventions after biologic initiation than before. A May 2025 study asserted that the use of biologics may have reduced the need for surgical intervention in their cohort. And a November 2025 study reported that recent advancements in biologics and immunomodulators have reduced the need for surgical interventions, close quote. So treat early and aggressively. But if your patient already has remodeled tissue, don't add a surgical delay on top of diagnostic and therapeutic delays. HS procedures should be performed after optimizing medical management and controlling inflammation, however, so don't proceed too prematurely. Should patients stop atopic dermatitis systemics perioperatively? 2 recent studies presented at the November 2025 annual scientific meeting of the American College of Allergy, Asthma, and Immunology found that atopic patients have innately higher surgical complication rates. The first compared over 20,000 women who had reconstructive surgery after breast cancer. Those with atopic dermatitis had 10 to 40% increased rates of complications, including infection, capsular contracture, implant rupture, and revision or removal surgery. The second was a study of over 38,000 adults who had bone graft surgery. The atopic patients demonstrated 16 to 35% higher rates of infection/wound complications, osteomyelitis, mechanical loosening, surgical revision, and hardware removal. These findings suggest that atopic immune dysregulation impairs wound healing, not just in the skin but elsewhere as well. Does it follow that systemic therapies that control atopic inflammation also improve healing? We don't yet have that data, but it's plausible. Most of the data we do have comes from other diseases. A systematic review and meta-analysis concluded that discontinuing methotrexate may actually be, quote, harmful, close quote, in terms of surgical site infections in rheumatoid arthritis and Crohn's patients. And the 2024 National Psoriasis Foundation guidelines state that biologics and DMARDs, including cyclosporine, can be safely continued in low-risk procedures and are, quote, likely safe to continue, close quote, in intermediate/high-risk procedures due to similar infection and wound complication rates. In AD, an intact skin barrier with less staph aureus colonization via restored keratinocyte and antimicrobial peptide function and reduced scratching could theoretically reduce surgical infection risk. Also, preventing flares reduces steroid exposure, which can impair healing and increase infection risk as well. And some AD biologic randomized controlled trials do show lower infection rates generally compared to placebo. That's why in one case report, dupilumab was strategically prescribed prior to high-risk cardiac surgery to reduce skin inflammation and colonization in a severe atopic dermatitis patient. Does the slightly broader immune modulation of JAK inhibitors require a different risk-benefit calculus? Currently, various expert guidelines recommend pausing for 3 days before surgery, then restarting when healing is progressing satisfactorily without evidence of infection. Fortunately, for many patients, 3 days is not enough time to flare. JAK's VTE risk is not acutely dose-dependent, though, so post-op thromboprophylaxis should be optimized. Maybe when the JAK data catches up, its guidelines will mirror those for older small molecules. For now, recommend the 3-day break to your patients on JAK inhibitors, but for those on biologics, treating through may be advantageous considering their safety profile and potential to mitigate the impaired healing and increased surgical complications caused by atopic inflammation. Before you IND a forehead abscess, make sure it's not a Pott Puffy tumor. A Pott Puffy tumor might sound like an adorably gruff and corpulent malady on toddler TV, but Pott Puffy tumors are a neurosurgical/ENT emergency. The pitfall for dermatology clinicians is that we treat abscesses and inflamed cysts so often that when we see a rapidly enlarging mass on the central forehead, we reflexively want to lance it. But Pott Puffy tumors are subperiosteal, not dermal or subcutaneous abscesses, with frontal bone osteomyelitis and a high rate of intracranial extension estimated to be 38% per a June 2025 systematic review and 71% in children and adolescents, according to a 2020 review. A simple outpatient IND may actually worsen a Pott Puffy tumor, not to mention delay proper surgical and IV antibiotic therapy, leading to intracranial infection spread, epidural/subdural abscess, meningitis, encephalitis, brain abscess, and dural venous sinus thrombosis, i.e. stroke. In addition to furuncle and epidermoid cyst, potential differentials include lipoma, hematoma, osteoma, and malignant neoplasm. So how do you distinguish a Pott Puffy tumor from one of these more common derm concerns? Red flags include recent rhinosinusitis or head trauma, edema that's fixed to the bone, facial pain or headache, fever, and vision disturbance. If there's intracranial involvement, add nausea or vomiting, photophobia, hemiparesis, seizures, and altered mental status to the list as well. So your patient is flying all the flags. Now what? Send them to the emergency department with CT for contrast or MRI, broad-spectrum IV antibiotics, and admission for multidisciplinary medical surgical management. And include a quick handoff note conveying your suspicion with rationale so the ED doesn't treat them and street them either. The mean hospital stay in the 2025 review was 23 days. So remember, first, do no harm, and second, don't get catfished by a Pott Puffy tumor. P.S. Now that you're confident that you can resist the temptation to drain a Pott Puffy tumor, a case published November 12, 2025, in JAMA Dermatology had none of the above red flags. No trauma, no recent surgery, no nasal congestion, no headache or fever. Even his CBC was normal, but he was HIV positive and had an elevated CRP. An MRI and strep pyogenes positive culture confirmed a subperiosteal abscess secondary to frontal sinusitis, and the patient was referred for endoscopic sinus surgery, IV antibiotics, and antiretroviral therapy. This case highlights the elevated risk among immunocompromised individuals, so look for that red flag too. And interestingly, the authors cite intranasal substance abuse as a risk factor as well. Is it okay to prescribe finasteride or spironolactone for breast cancer survivors with androgenetic hair loss? What about methotrexate or a JAK inhibitor for alopecia areata triggered by an immune checkpoint inhibitor? About 1 in 8 women in the U.S. will have breast cancer, and at least a third of U.S. women will have some form of hair loss. But many hair loss treatments are immuno or hormonal modulators, causing reluctance to treat in many prescribers. A review article published November 1st, 2025 in the American Journal of Clinical Dermatology looked at the safety of treatments for androgenetic alopecia, alopecia areata, and cicatricial alopecia in women undergoing breast cancer therapy, women with a history of breast cancer, or women with an elevated risk of breast cancer. So which medications are safe? Thankfully, both topical and oral minoxidil made the cut. In fact, it's often used for chemotherapy-induced alopecia. Perhaps surprisingly, spironolactone is okay and does not interact with endocrine therapies. Ketoconazole 2% shampoo, which has mild anti-androgen properties, is okay due to minimal systemic absorption. Corticosteroids, including topical, intralesional, and oral, made the safe list. Be aware, however, that although it was not addressed in this review, systemic steroids within the first few months of immune checkpoint inhibitor therapy may negatively impact response. Methotrexate is also okay and, in fact, used to be a common breast cancer treatment. Topical calcineurin inhibitors are minimally absorbed and have been studied in breast cancer-related lymphedema. Doxycycline actually has anti-tumor growth and metastasis properties, and metformin reduces breast cancer risk in some individuals by lowering insulin-like growth factor, which is mitogenic for breast epithelial cells. The following medications may be considered with caution. 5-alpha reductase inhibitors such as finasteride, dutasteride, saw palmetto, and pumpkin seed oil, as they mildly increase estrogen levels, but studies show no increased breast cancer risk. Bicalutamide may increase testosterone and estrogen levels. Platelet-rich plasma has limited data in breast cancer patients. JAK inhibitors have an FDA box warning for malignancy, of course, but the risk appears lower in dermatology versus rheumatology populations. And counterintuitively, several papers have been published in the last couple of years exploring the use of JAKs to improve immune checkpoint inhibitor efficacy while also reducing adverse effects. So there may be a synergistic opportunity there, but obviously consult with oncology first. Diphencyprone, or DPCP, has minimal systemic absorption, but data is limited. Hydroxychloroquine should be avoided with tamoxifen due to increased retinal toxicity. Mycophenolate mofetil may have anti-tumor effects, but data is limited. High-dose naltrexone can interfere with opioid growth factor-mediated tumor suppression, but low doses can have an anti-proliferative effect via a rebound upregulation of OGF receptor expression. Pioglitazone has an unclear impact on breast cancer risk. The following medications are contraindicated. Oral contraceptives, of course, increase breast cancer risk in both current and recent users. Cyclosporine has an FDA boxed warning for malignancy. Azathioprine conveys a potential elevated risk of both breast cancer recurrence and metastatic progression. Bottom line, don't add to these patients' body image disturbances by shying away from their hair loss. Make evidence-based choices to help them become alopecia survivors too. And that wraps up episode 21. Derm Drop is written and hosted by me, David Sider, with distribution and administrative support by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Seiter, spelled Seiter. Questions and comments can be sent to us at dermdrop@gmail.com. And if you had a good time and learned something useful, give us some love with a thumbs up, 5 stars, comment, or review, and be sure to tell your colleagues. Thanks for listening, and tune in again in 2 weeks for more dermatology quick picks in the next episode of Derm Drop.